Okay, hi everybody. Welcome back to Biology 233's screencast of the respiratory system PowerPoint. So, when we left off, we were talking about the respiratory membrane and how that works. And today we're going to talk about the rest of it. So, blood supply to the lungs, how pulmonary ventilation works, what happens to the blood when it gets to the alveolus, and all that good stuff. So, let's get started. So, double blood supply to the lungs is similar to the double blood supply to the heart. So, in the heart, there are vessels that take blood to and away from the heart because the heart is a pump and that's what it's supposed to do. Some of that blood goes to the lungs to pick up oxygen and then returns to the heart to get pumped elsewhere. And that is part of the blood supply to the lungs. The other part is the part of the blood supply to the lungs that nourishes the tissues of the lungs themselves, because of course your alveolar cells, great and small, and your alveolar macrophages are all living cells that respire and they use oxygen and they create waste and they need that waste to get carried away. They're producing carbon dioxide, they're absorbing oxygen and all kinds of things. So, the deoxygenated blood arrives through the pulmonary trunk from the right ventricle. So the purpose of this bullet point is for the blood to pick up oxygen. The bronchial arteries branch off of the aorta, and this tells you that this blood is O2 rich, meaning that this is the blood that's going to nourish the lung tissue itself. Venous drainage from the lungs returns all of the blood to the heart. And as we know, there's less pressure in the pulmonary veins, meaning that if you have an artificial increase in that pressure for some reason, that's going to cause problems like pulmonary edema. Pulmonary blood vessels constrict in response to low oxygen levels so they don't pick up CO2 on their way through the lungs, because there's lots of CO2 being dropped off there as well. Oops, hold on just a second. Back. All right. Pulmonary ventilation. So pulmonary ventilation is the act of breathing, so drawing air in and expelling it. So air moves into the lungs when pressure in lungs is less than atmosphere pressure. So we can say P lungs, so P sub L, is less than P sub A, atmospheric. So this is accomplished by primarily the diaphragm. Air moves out of the lungs when pressure inside the lungs is greater than atmospheric pressure. So this is kind of like depressing a bellows. If you know what a bellows is, it's an old-timey instrument that allowed you to pump air out of fire. So accordions also contain a bellows, as do bagpipes. So when P inside of the lungs is greater than the pressure of the atmosphere, that means you're pushing air out. So we accomplish this by moving diaphragm up and compressing our thorax. So atmospheric pressure, which is the pressure in the air in most places on the earth, is 1 atmosphere. That's what ATM means, not automated teller machine, or a measurement unit that you might be more familiar with, 760 millimeters of mercury, so you know about millimeters of mercury from blood pressure. So Pleurae and the pleural fluid. So to illustrate this point, let's really quick draw ourselves a pair of lungs. And then this is the left lung because it has the cardiac notch. You'll learn more about that in a little bit. So now I'm going to get a different color and let's draw the visceral pleura, which lines the lung surface. I'm going to draw it as close to the lung surface as I can. So this is the visceral pleura. It lines the surface of your lungs. And if I get another color here, let's draw the parietal pleura in a slightly darker green. Just like so. So the pleural space, or pleural cavity, is the space between the two layers here. And that contains fluid, which helps to reduce friction and also assists the pressure gradient. So because the pleural fluid is made mostly of water, and water likes to stick to other water. The visceral pleura and the parietal pleura are going to want to stick to each other due to the surface tension of water, and that helps pull the lungs open and create lower pressure in the lungs to assist in lung inflation. It also helps to compartmentalize the lungs so that if you get an infection in a nearby tissue, it's difficult for the infection to spread to the lungs, and conversely, if you get a lower respiratory infection, it's difficult for the infection to spread from the lungs. So let's put i.e. pneumonia, etc. So if I'm a little bacterium, let's draw one. Let's make him red. There he is. He's angry. He's going to try to leave the lung and go somewhere else, but can't. Stuck in the lungs. Hopefully to be eaten by a macrophage. So here's another view. So this is a transverse section of a human being. And here is a illustration very similar to the one I just showed you. So the visceral pleura covers the lungs. So this is going to be the visceral pleura in red here. And the parietal pleura lines the rib cage and covers the upper surface of the diaphragm as well. So you're seeing the pleural space or cavity right here. Okay, so we have to actually get into some physics here, and if you're balking because you're like, oh no, physics, don't worry. I'm not going to make you do almost any math. You just need to understand these laws. Now, they're all named after dudes: Boyle, Charles, Dalton, and Henry. And there aren't really any alternate names for these, so you're just going to have to memorize these guys' names. So Boyle's law is the one that we use to perform pulmonary ventilation with. So the pressure of a given quantity of gas, now when we see the words given quantity, that means a set and unchanging volume. So if I give you let's say a room-sized amount of gas, like 10,000 cubic liters, and I ask you to put that gas into a cooler-sized space, which is much smaller, the pressure is going to go up because you're pushing those gas molecules closer together, and they're going to run into each other more often, and that is Boyle's law. So the larger the space, the lower the pressure. The smaller the space, the higher the pressure. So volume and pressure are inversely proportional. This is assuming a constant temperature as well because of Charles' law. So let's say you have some gas in a soda can. It's just a can full of gas, that's all. But then you heat that sucker up. The gas molecules in the can are going to run into each other more often, and that's going to increase the pressure and maybe even burst the can. So now we have a proportion instead of an inverse proportion. So as temperature goes up, so does gas volume, and therefore pressure. Dalton's law. Oh, and this is assuming a constant environmental pressure, not the gas itself. Dalton's law states that the total pressure of a gas mixture is equal to the sum of the partial pressures of its individual gases. So the air we breathe is not just oxygen, it's a mixture. So it's got nitrogen and hydrogen and CO2 and water vapor and oxygen and trace amounts of other gases as well. So it's got a lot of different kinds of gas molecules bopping around in our atmosphere. So if you add up the partial pressure of each of these, you should get 1 atmosphere in our atmosphere. And we're going to look at more Dalton's law stuff in a little bit when we talk about gas exchange. So Henry's law means that the air-water interface, which is the interface between the air you breathe in and your alveolus, because the inside of them is wet, the amount of gas that ends up dissolving in that water is determined both by its solubility in water, and its partial pressure. So if I have a highly soluble gas in a mixture, let's say carbon dioxide, it's pretty soluble compared with water, but I don't have very much of it, not very much is going to dissolve. If I have a high solubility gas that is very, very present and takes up the lion's share of a gas mixture, then a lot of it's going to dissolve in. Okay, so pressure and flow. atmospheric pressure drives respiration. So we already established that 1 atmosphere is 760 millimeters of mercury. So intrapulmonary pressure and lung volume have an inverse proportional relationship. So intra, remember, means within. So this is the pressure inside of the lung. So pressure is inversely proportional to volume. So for a given amount of gas, as volume increases, pressure will decrease. So if I move my diaphragm down and create more space inside of my thorax, due to Boyle's law, the pressure is going to drop, and that means that air from the outside of me is going to move in. And as volume decreases, pressure increases, and that's going to push air out. So the difference between atmospheric and intrapulmonary pressure creates the driving force for air to move into and out of your lungs. So this is created by changes in the volume of the thoracic cavity, primarily due to your diaphragm, but also due to your intercostal muscles and some other things. All right, speaking of muscles, the diaphragm is dome-shaped. That should be hyphenated. That's me being a grammar dork. So contraction flattens the diaphragm. So when I take a deep, 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 deep breath, what I'm doing is I'm making my diaphragm go from this state to this state. And if this is the volume of my thorax, the striped area is the area that was not available to me before, and now I have that much more volume. So this is air moves in. The scalenes are a set of muscles that fix the first pair of ribs and can lift them up slightly. The external intercostals elevate the 2nd through 12th pairs of ribs. And you also have the pectoralis minor, the sternocleidomastoid, and the erector spinae muscles. So if you really take a deep breath and labor to get as much air as possible into your lungs, you're going to be really calling on all of these muscles, all of them, to inspire extremely deeply. So as intrapleural pressure decreases, the volume of the thoracic cavity increases while this is happening, and the visceral pleura clings to the parietal pleura. And I already explained this. Part of this is due to the surface tension of water. If you get a decrease in intrapulmonary pressure, lungs expand with the visceral pleura, and that allows the visceral pleura to contact the parietal pleura. So the transpulmonary pressure is intrapleural, so within the pleura, minus intrapulmonary. Not all the pressure changes transferred all the way to the lungs. So why is this important? Well, if you change transpulmonary pressure, you can change the ability of somebody to inflate their lungs. So if you get blood or air in the pleural space, that's going to change your transpulmonary pressure and make it really hard for you to take a breath. So the inflation of lungs is also aided by the warming of inhaled air, because as we know from, let's go back a couple. As we know from Charles's law, there is a relationship between pressure of air and movement of air and temperature. So when you're doing resting quiet breathing, so just chilling, breathing quietly, probably not thinking about breathing, should say a quiet breath, not a quiet breathe, flows about 500 mils of air through the lungs. And I'm saying about because this is going to vary by body size, of course, like everything else does. So here we have a representation of what this looks like. So we're showing at rest, the diaphragm is dome-shaped. Atmospheric pressure is close to, intrapulmonary pressure is close to atmospheric pressure. Intrapleural pressure is about 4 millimeters of mercury less, so the net transpulmonary pressure is 4. During inspiration, both of these are going to go down, so from 760 to 757, and from 756 to 754. And that's going to have the lung surfaces stick to the pleura and expand, and also the diaphragm is going to move downward and pull the thorax into a larger volume. During expiration, it's not that you contract your diaphragm in the opposite direction, you just let it relax and it goes back to being dome-shaped. And then you get a loss of intrapleural pressure, but an increase in intrapulmonary pressure because you're squishing your lungs physically, so air is going to leave. So as I mentioned, passive expiration is during quiet breathing, and that's due to the elasticity of the lungs and the thoracic cage and the natural recoil of your diaphragm. So, as the volume of the thoracic cavity decreases, intrapulmonary pressure increases and air is expelled. So you go after inspiration, so once you go the phrenic nerves continue to stimulate the diaphragm to produce a braking action to elastic recoil. So go ahead and do the following for me. Inspire, but don't close your glottis, so don't close your throat off. Just inspire for a minute and then stop without closing your throat. That represents this last bullet point. So you're continuing your stimulation of the diaphragm to prevent the elastic recoil from bounding back and pushing the air out of you. Okay, forced expiration. So this is things like coughing, sneezing, screaming, yelling, singing really hard, those kinds of things. Any time where you have to engage extra muscles to really squish air out of your thorax, this is forced expiration. So the internal intercostals are muscles of forced, not passive, but forced expiration, and these depress the ribs. So they take your rib cage from being lifted and open to being compressed and closed. And you can also contract your abdominal muscles. And this functions to increase abdominal pressure, which forces the diaphragm upward and increases pressure on the thoracic cavity. So the best way to observe this component is watch a little kid or a toddler throw a tantrum. When they rev up and get ready to scream, especially if they're standing up, you might notice that at the onset of the screaming, they kind of lean forward a little bit to really get that last little oomph out of their voice. That's them contracting their rectus abdominis to make their shouting extra loud. Adults don't tend to do that as much because we're a little bit more conscious of our body posture and our behavior, but uninhibited kiddos do this very observably. Okay, so earlier I mentioned that changes to the transpulmonary pressure can be very dangerous to your ability to take in air. So pneumothorax is one example of that. So pneumo means air and thorax means in your thorax. So the only place in your thorax that air should be with any regularity is inside of your lungs. If it's between your lungs and other tissue, then you have pneumothorax, and that is not good. So the pleural cavities are sealed and they're not open to the outside. If you get air in your pleural cavity, this usually happens due to trauma, stabbing or puncturing, which is arguably also trauma. It can also happen with crush injuries. There's a condition called flail chest. I'm not going to show you a video of it because it's pretty traumatic, but you can look it up if you like. Go with caution on that one. It's pretty gnarly. You get a loss of negative intrapleural pressure, and that allows the lungs to recoil and collapse. So that's what a collapsed lung means, is that the ordinary intrapleural pressure that sticks your lung surface to the inside of your chest cavity and helps to hold your lungs open against that elastic recoil is absent. So the collapse of the lung, or part of the lung more often, is called atelectasis. So injuries to the chest wall that let air into the intrapleural space cause this. And it's always on the same side as the injury, because that makes sense, right? The two pleural cavities aren't connected to each other, so why would it cause a contralateral effect? Okay, resistance to airflow. So one of the major factors, in addition to changing volumes and such, is that you have to deliver air to your lungs through a tube. And your lungs are stretchy and they have some elastic recoil because there's elastic fibers in their walls. So pulmonary compliance can be thought of as stretchiness of the lungs. So how easy is it for your lungs and chest wall to expand? And that depends on how elastic your lungs are and on surface tension due to the pleural fluid. And the lack of surface tension on the inside. So there are diseases that reduce pulmonary compliance. So tuberculosis is one. In tuberculosis, you get scar tissue that forms on the lungs. So lost lung tissue is replaced with collagen, and collagen is way less stretchy than elastic fibers. Pulmonary edema is fluid in the lungs, and when you have pulmonary edema, that means that your surfactant is diluted. So when we say reduced here, we don't mean it's produced less, but it's actually dilute and therefore less effective. So the insides of your alveoli are going to tend to collapse and stick to each other. And of course, also paralysis. So if you get a spinal cord injury above a certain point, you can get paralysis of the nerves that allow your inspiration processes to occur, specifically the phrenic. And that's going to create a situation in which you are unable to expand your diaphragm and chest cavity. Bronchiolar diameter is another one. So remember, diameter is the distance across a tube. And this is actually the primary control over resistance to airflow. So if you want to prevent airflow, if you want to block air from getting into the lungs, you can close off the tubes that go to the lung, and that really effectively prevents this. So bronchoconstriction is the name for that process, and it's triggered by all kinds of things. So airborne irritants, like let's say you're running through a burning building, your bronchi are going to constrict to reduce the amount of smoke that's able to hit your lungs. Cold air is another one. So that feeling in your chest when you go from inside to outside on a really cold day and that bracing air hits your lungs, that's that. Parasympathetic stimulation as well, that's involved in bronchial tone, and also histamine. Bronchodilation is the opposite, so this is going to make the diameter of your bronchi bigger. Sympathetic excitation does this, so if you're in the middle of a fight or flight situation and you need to deliver more oxygen to your blood and oxygenated blood to your tissues and so on and so forth, they are going to dilate as well to facilitate the passage of air to your lung surface. And epinephrine, a catecholamine, also does this, and that naturally follows from sympathetic innervation because epi and norepi are both features of the sympathetic nervous system. Another thing that can perform bronchodilation is steroids. So if you have asthma and you are subject to spontaneous bronchi or bronchiolar constriction, you can take albuterol, which is a steroid that is going to relax the smooth muscle in your bronchi and bronchioles and help you breathe easier, because during an asthma attack, it really feels like you're breathing through a straw. Okay, so alveolar surface tension. And this is going to go back to the concept of hydrogen bonding. Yes, I bet you thought you were done with hydrogen bonding forever, but you're not. Hydrogen bonding is a very, very strong determinant of the way our breathing works. And it's a double-edged sword because you actually need a thin film of water. That's why it says necessary here. You need a thin film of water that is necessary for gas exchange. And that's because you can't dissolve gas across a dry surface. You need it to be able to dissolve into some sort of wet interface in order for effective gas transfer to happen. But surface tension is going to want to make the walls that are coated in water, this thin film, to cling to each other. So think of a time when you got the inside of a plastic bag wet. Wet plastic bag. So if you're curious about this, you can do an experiment. Just go get the inside of a plastic bag wet. I think you'll find that the wet parts cling to each other and inhibit you opening the bag. So this is where surfactant comes in. So surfactant's produced by septal cells. And this disrupts the hydrogen bonds of water, which reduces the surface tension. And that allows your alveoli to stay open. So anything that disrupts this bonding is a mild detergent. And pulmonary surfactant does exactly this. So as passages contract during expiration, surface tension naturally decreases and surfactant concentration increases, preventing alveolar collapse. Respiratory distress syndrome, or IRDS, infant respiratory distress syndrome, let's write that down. This happens in premature infants if the infant is born and delivered prior to the developmental time when they have been able to create enough surfactant. So this means that it's almost impossible for them to inflate their lungs because they're trying to overcome surface tension. You get something called costal breathing, where they're working so hard to breathe that you can see their rib cage moving in and out. And it's very scary and requires a lot of help in the NICU, the neonatal ICU, for these kiddos to get through that challenge. So that's why being born too early isn't a good thing. All right, so with regard to alveolar ventilation, there's dead air. So dead air is the air that's in the airway that cannot exchange gases. So remember, the upper respiratory tract and parts of the lower are just tubes and spaces that contain and move air. They don't actually do any gas exchange, so you're not trading oxygens for carbon dioxides. So this air is considered dead because, yeah, it's in your body, but it's not being used for any purpose. So the anatomic dead space is therefore the conducting division of the airway. So let's annotate this to say for air movement, not gas exchange. So the physiologic dead space is adding up the anatomic dead space, which everybody has and you always have, with any pathological alveolar dead space. So this can come from COPD or tuberculosis or injury or cancer, anything that causes you to lose lung tissue, basically, or have portions of your lung where gas exchange doesn't occur. The alveolar ventilation rate is the air that actually ventilates the alveoli, so it has to touch an alveolus, multiplied by the respiratory rate. So it would be great if every single air molecule that you took into your body descended to your lungs, was exchanged perfectly efficiently, and then waste products were expelled, but that's not how it works. So this is directly related and relevant to the body's ability to exchange gases, the alveolar ventilation rate. Oops, all right, so breathing patterns. So these are medical terms for different patterns of breathing, and you may see these on medical charts if you're going into nursing or emergency medicine. Medical charting and accurate reporting of observed symptoms and changes in patients is critical for providing good healthcare. And that's actually one of the reasons that we are such sticklers at PCC and in other courses about you guys spelling things correctly and using correct and precise terminology. Because eupnea is normal, quiet breathing. So this is a patient that's having no problems. Apnea means that they're occasionally not breathing at all. These two are very, very different, even though the words are similar. So you need to be able to show me that you can memorize which is which, because it's a very, very serious error if you were to say chart that incorrectly in your jobs going forward. So I know everybody's harrowed by the spelling and grammar and language precision problems of this course. I see that all the time, but I want to assure you that there's a very good reason for it, and we start training you on how to do that very early so that you don't arrive at nursing school or PT school and then find yourself surprised by all of this vocabulary that you're supposed to know. So dyspnea is a little bit vague, so it's any difficulty or labor with breathing, and of course the etiology or cause of dyspnea is pretty variable, so it can be due to a lot of different things. Tachypnea is rapid breathing, so this root word should be familiar to you by now. Remember, tachycardia means rapid heart rate. Tachypnea means rapid breathing. Diaphragmatic breathing is the descent of the diaphragm that causes the stomach to bulge during inspiration. So if you take yoga, your yoga instructor might call this belly breathing. I've noticed that yoga and Pilates instructors are really into talking about bellies during respiratory discussions for some reason. So this is what they mean. It's just the kind of breathing where you really take a deep breath in and it causes your abdomen to move out. Costal breathing means just rib activity is involved. So you're using your internal and external intercostals, but you're not using your diaphragm. And this is usually indicative of some sort of problem. Either you've got a problem with the phrenic nerve or super labored breathing and your diaphragm is spasming and it's running out of energy, etc., and so forth. So modified respiratory movements. This is any time you move air in or out in a way that's not related to respiration directly. So coughing is a deep inspiration, closure of the rima glottis, so your vocal cords are going to come together, and then strong expiration blasts out to clear the respiratory passages. Now, why would you want to close the rima glottis instead of just exhaling strongly? Well, when you close this and push up, you allow the pressure behind the rima glottis to reach really, really high levels, and then when you release it, the goal is to suck stuff that might be in your lower tract up and out. Hiccuping is when your diaphragm is confused about what its job is. So you get a spasmodic contraction of the diaphragm and quick closure of the rima glottis, and that produces a sharp inspiratory sound that's often high-pitched. And this is one of those things where you kind of just have to wait it out. Everybody has their own little remedy for how to stop hiccups, but they work differently for different people because, hey, everybody's neurology is slightly different. Come on, advance. Okay, so non-respiratory air movements. So these are functions other than alveolar ventilation, so anything that you do that's the point of it isn't to breathe. So flow of blood vessels and lymph from abdominal to thoracic vessels is one reason you might want to do this. So you can change the pressure in your thorax to redirect blood flow and lymph flow. So we talked about this a little bit when we talked about the lymphatic system and the vessels. So there was the skeletal muscle pump for venous blood returning from below the heart. And we also talked about the thoracic pump, such that when you create negative pressure in your thorax, blood is drawn up into the tubes like the same kind of principle as when you suck blood through a straw. Hopefully you don't suck blood. Suck a beverage through a straw. So variations in ventilation also serve speaking. So you have to breathe in and out in a particular way in order to speak. And also yawning, sneezing, and coughing. The Valsalva maneuver is a particular breath-holding maneuver. It's one of my favorites. It has a particular name because it's useful for expelling things. So it's useful for trying to speed up the process of micturition or urination. It's useful for quote-unquote straining on the toilet to get feces out, and it also is really helpful in childbirth. So you take a deep breath and you hold it in, and then you contract your abdominal muscles, and that increases pressure in the abdominal cavity to move things from in there to no longer in there. Okay, so let's say you're a doctor and somebody is reporting changes to their ventilation, but they can only report those qualitatively. So what they feel like, how their breath feels, how hard or easy it is to breathe, but you're a clinician, so you want numbers around this thing. So measurements of ventilation can be achieved using a thingamajig called a spirometer, and a spirometer is basically a small device that measures how much and how hard you breathe into it. And we actually have these in the lab, so you'll get to play around with some rudimentary spirometers, so they're not computerized like modern ones, but you can sort of get the experience. And these allow you to estimate and measure respiratory volumes. So a volume means volume of air. So the respiratory volumes really mean how much air are you moving by doing different things. So tidal volume is the amount of air inhaled or exhaled in one quiet breath. So your average tidal volume is about 500 milliliters or so. Your inspiratory reserve volume is the air above tidal volume that can be inhaled with maximum effort. So this is the volume where you inhale, and then you keep trying to inhale more and more until you can no longer inhale. That's your inspiratory reserve volume. Your expiratory reserve volume is the air in excess of tidal expiration that can be exhaled with a maximum effort. So really squishing all the air out of your lungs as much as you possibly can. However, it's impossible to get all of the air out of your lungs unless you were to wring your lungs out like a sponge. So the air that's left over is the residual volume, and that's just whatever's left over after your expiratory reserve volume is exhausted. So here's a picture of this. So you can see this middle area where there's nice quiet breathing that is oscillating between about 2,500 and 3,000 milliliters. This is quiet breathing, so this is your tidal volume, which is here. Now, the distance between where the blue ends and the yellow begins and the very top, that's your inspiratory reserve volume. Now, most people, these are averages obviously, most people have an inspiratory reserve volume such that they are able to get up to about 6 liters of air. So the difference between 3 and 6 is, of course, 3,000 milliliters or 3 liters. Because 6 minus 3 is 3. Your expiratory reserve volume is a little bit different. So that is going to be, after you exhale regular style, you're going to keep breathing out until you can't breathe out anymore. So that gets you from 2,500 to about 500, so that's only around 2,000. Oopsie, sorry. 1,500. So 1,000, my bad. The residual volume, this is the stuff that's left over. And the vital capacity is the difference between your expiratory reserve volume and your inspiratory reserve volume. So this basically gives you a snapshot of how much air you're capable of moving in total. Your total lung capacity adds the vital capacity to whatever's left over. So that's how much air you can have in your lungs at all. So let's look at the same thing in words. So vital capacity is the amount of air that can be exhaled with maximum effort after a maximum inspiration. So breathe in really, really deep, and then breathe out really, really deep. And one of the usefulnesses of this particular test is to assess how strong your thoracic muscles are and pulmonary function, specifically compliance. Inspiratory capacity is the maximum amount of air that can be inhaled after a normal tidal expiration. So this also tells you about compliance. And functional residual capacity is however much is left in your lungs after a normal tidal expiration. Total lung capacity is that line I showed you, so the maximum amount of air that the lungs are capable of containing in total. And then forced expiratory volume is the percent of vital capacity exhaled per unit time. So in a healthy adult, this is about 75 to 85% of your vital capacity inhaled in 1 second. So you're going to breathe out really fast and hard. If you see a problem with this, so let's say it takes somebody longer or they get less percent out in 1 second, that means that there is a problem with obstruction. So it's indicative of an obstructive lung disorder. And this just means that basically a tube is blocked or the tubes are too narrow. Peak flow is the maximum speed of exhalation. So this is talking about rapidity or speed rather than volumes. And the minute respiratory volume, note this is minute as in the unit of time, not minute as in tiny. This is the tidal volume times how often you're breathing. So how much you breathe times how often you breathe. And at rest, that should be around 6 liters per minute. Maximally, it can be up to 170 liters per minute. So when you're really, really working hard, really breathing in and out. All right, the effects on respiratory volumes and capacities, and this should say effects. An affect is something different. Bad ed. So age is a major one, and this shouldn't come as a surprise to anybody because you get sort of less elastic and less stretchy and less capable as you get older. So you get a weakening of the respiratory muscles. And I'm going to put an asterisk there because that means you do get a weakening of respiratory muscles if you let them atrophy. So you can do something to take care of this part of the equation if you just engage in exercise regularly enough, but lung compliance you can't really do anything about. Over time, your ability to create stretchy elastic fibers diminishes with age, and that's kind of just a fact. So exercise maintains the strength of the respiratory muscles, but you can't really do anything much about compliance. Body size also determines respiratory volumes and capacity. So if you have a really big body, you probably have big lungs. Restrictive disorders decrease compliance and vital capacity. So this would be things like tuberculosis, COPD to some effect, anything that makes your lungs less stretchy and you have lung tissue less ability to expand. And obstructive disorders interfere with airflow. So this means that expiration, so breathing out, requires more effort or is less complete. All right, so we are at 41 minutes, which is just about the limit of how much YouTube can handle as far as video length with reasonable upload time. So I'm going to stop here on neural control of ventilation. Seems like a good stopping point. And we will pick up next lecture by talking about how the brain, particularly the brain stem, controls ventilation. So this is why you don't want a brain stem injury. And how these change between consciousness and unconsciousness, because obviously you can breathe while you're asleep as well as when you're awake. So that suggests that there are different brain areas that are in charge of different things, allowing you to pull that off. So thanks for your attention, and I will see you next time.